Hello, I'm Ernest Choi from Cardiff University in the UK. Unfortunately, I can't be with you in person, but I'd like to thank the organizer not only for inviting me to give this talk, but allow me to do this in the virtual space. So this talk is about emerging medications in rheumatoid arthritis, particularly try to address the question, do we need more? So these are my disclosures. So as rheumatologists, we are rather fortunate because over the last 2 decades, we have biologic DMARDs covering 5 different classes with 9 different agents having been approved for the treatment for rheumatoid arthritis. And over the last few years, we have also added to the biologic DMARDs by the targeted synthetic DMARDs. These are the JAK inhibitors, and a number of these have been used worldwide, particularly tofacitinib and baricitinib for a while. But in the last 2 years, upadacitinib has been approved, and filgotinib has just been approved in Europe for the treatment of rheumatoid arthritis. And in case you're not familiar with the last two, these are the ACR 20, 50, and 70 response of phase 3 clinical trials of upadacitinib in patients with rheumatoid arthritis, ranging from biologic failure patients to methotrexate failure patients to methotrexate naive patients, and then head-to-head comparison as monotherapy with adalimumab. So it shows that JAK inhibitors are not only effective for the treatment of rheumatoid arthritis, the efficacy is comparable with existing biologic agents. And for filgotinib, we can see data in, again, biologic failure patients, methotrexate failure patients, as well as methotrexate naive patients, as presented on this slide. Now, in terms of efficacy, a recent meta-analysis trying to compare the different JAK inhibitors shows that, in fact, the ACR 20, 50, and 70 response rate are very similar to what we expect from biologic DMARDs, and there are very little difference amongst these agents. One thing that is an issue with these new treatment is that we don't have long-term safety data, and for the safety data in clinical trials, this has been compared using meta-analysis again, and in terms of serious infection rate, at least within the clinical trials, in this meta-analysis, tofacitinib and baricitinib seems to be associated with increased infection risk, very similar to what we have expected from biologic agents, so no issue there. I guess the only exception to this rule is the reactivation of herpes zoster. This is data from the German rabbit registry showing that there is a higher rate of zoster reactivation associated with JAK inhibitors compared with other biologic agents. But reactivation of zoster can be reduced by vaccinating the patient with zoster vaccine, and it usually doesn't lead to serious consequences. So this is not a major concern. I guess the issue that has been more challenging recently has been raised by a specific trial of tofacitinib. So in this, what is known as the oral surveillance study, it looked at adverse event associated with 2 different doses of tofacitinib, 5 and 10 milligrams BID, and compared this with a TNF inhibitor. And in this study, of a very large study, in fact, you can see that in each of the arms, there were more than 3,000 patient years of data. There was an increase in venous thrombosis rate. So compared with TNF inhibitor, which is the reference the hazard ratio of DVT is over 2 with the 10 milligrams BID group, and with PE is 5.96, and this difference was statistically significant. In the 5 milligrams BID group, the hazard ratio was increased, although this did not reach statistical significance. So these suggested that particularly at high doses, tofacitinib may be associated with venous thrombosis, and that has led to the Medicines Agency in Europe recommending patients with rheumatoid arthritis should not be treated with 10 milligrams BID, but it still suggested a slightly increased in rate in the 5 milligrams BID group. Importantly, to emphasize is that although the hazard ratio suggested an increase in risk, the absolute risk, so the event rate, is still very low. So in the TNF reference group, there were 3 cases out of 3,000 patient years, and with tofacitinib, there were only 17 cases. So whilst there is a relative increase in risk compared with TNF inhibitor, the absolute risk is low even in the 10 milligrams BID group, and in the 5 milligrams BID group, the event rate was only 5. One challenge associated with that observation is that we don't completely understand the mechanism why tofacitinib may well be associated with venous thrombosis risk, and we don't know whether this is a class effect or this is associated with tofacitinib itself. Suffice to say that many observational studies have shown that patients with rheumatoid arthritis already have a higher risk of venous thrombosis already, and this is a UK population study showing that there is a 50% increased risk of venous thrombosis in patients with RA compared with non-RA patients. Recently, last year at the EULAR E-Congress, the WHO global database also suggested that the JAK inhibitors, either tofacitinib or baricitinib, was associated with increased reports of venous thrombosis event. So it would suggest that these venous thrombosis risks may not just be unique to tofacitinib, but may well be a class effect, something that we don't know for sure. Recently, we looked at venous thrombosis event in the upadacitinib clinical trials, and in that clinical trial program, there were 35 venous thrombosis events. But it's important to note that in the clinical trial program, the number of patients and the length of follow-up is restricted compared with the oral surveillance study. So in the clinical trial program, there were no increased rate of venous thrombosis in the upadacitinib group compared with either methotrexate or adalimumab group. But the sample size is probably too small for us to definitively say that whether venous thrombosis is associated with upadacitinib or not. So more recently, Pfizer also has a press release from the oral surveillance study about 2 other adverse events. The first is a major adverse cardiovascular event. And what it reported is that when you combine the 5 milligrams and 10 milligrams BID group, there was a slightly higher rate of cardiovascular event in the tofacitinib treatment compared with the TNF inhibitor. And what it shows here is that it cannot be, so the study was defined as a non-inferiority study. And this study shows that, in fact, you cannot conclude that JAK inhibitors, particularly tofacitinib in this case, is non-inferior to TNF inhibitor in causing cardiovascular, in association with cardiovascular event. And in fact, the same is true for malignancy, having excluded non-melanotic skin cancer. So you can see that the number of patients who have malignancy, 122 over 3,000 patients combined, was higher than 42 in 1,451 patients, giving a hazard ratio of close to 1.5. So while JAK inhibitors has increasingly been used and we are confident about their efficacy, there's still some question mark about safety. And this safety issue will need to be defined more clearly in future real-world registry study and large randomized trials. So I want to quickly review with you a couple of new treatments that are being in development for treating rheumatoid arthritis. So as you know, JAK inhibitors target the signaling transduction mechanism of IL-6 as a cytokine. But of course, the JAK-STAT pathway is not only used by IL-6, but other pro-inflammatory cytokines. And JAK inhibitors don't block IL-6 signaling pathway completely. To block IL-6 signaling pathway completely, we need something that target IL-6 itself. And we have two anti-IL-6 receptor monoclonal antibody in use at the moment for treating rheumatoid arthritis. This is tocilizumab and sirolimus. Now, another strategy to block IL-6 signaling is to target the cytokine itself. And I'm going to show you the data from a recent phase 3 study of olutasidenib, which is an anti-IL-6 inhibitor that binds to what we call the site 3 of IL-6. So this is a site that binds to GP130. So in this placebo-controlled trial, 2 doses of olutasidenib given either 2 weekly or fortnightly produced statistically significant improvement in ACR20 response when compared with the placebo-treated group, suggesting that anti-IL-6 monoclonal antibody can be effective in the treatment of rheumatoid arthritis. And in fact, olutasidenib is approved for the treatment of rheumatoid arthritis in Russia at the moment. So another monoclonal antibody targeting a different mechanism that has shown promise is an GM-CSF receptor monoclonal antibody called muralilimab. And in this placebo-controlled trial, you can see that compared with placebo in black, 3 doses of muralilimab achieve statistically significant improvement in either reduction in DAS-CRP on the left, the ACR20 response in the center, and also reduction in pain in this patient. And the improvement was achieved in a dose-related manner. And in fact, in a comparison trial with a TNF inhibitor, golimumab, muralilimab in blue, and golimumab in red, either in DMARD-IR or TNF-IR patients achieved fairly similar response rate. Another mode of action that has been investigated is an oral treatment. This is a treatment that targets the Bruton's kinase receptor, and the Bruton kinase is associated with the B cell receptor and can inhibit B cell activation. It is also involved in TCR signaling, so can also have some impact on the innate immune response. And in this phase 2 clinical trial of fenebrutinib, which is a Bruton kinase inhibitor, it shows that it achieves statistically reduction in disease activity as measured by the DAS-CRP and improvement as measured by ACR50 when compared with placebo-treated patients. So you may argue that, well, we have so many treatments approved for rheumatoid arthritis already, we are almost spoiled for choice, and we don't know which treatment to choose for which patients. Why do we need more? Well, the basis that we need more is this, that rheumatoid arthritis is in fact a very heterogeneous disease. So this is a UK study looking at the pathology inside the rheumatoid synovial joint in patients first presented with the disease. And in this study, it shows that histologically, Patients with rheumatoid arthritis at the time of presentation show very different histological features. One that can be dominated by lymphoid aggregates, one that is dominated by diffuse macrophage infiltration, and lastly, there's a type that is characterized by increase in fibroblasts in the joint without many inflammatory cells. And by expressing the genes that are expressed in this tissue using transcriptome profiling, what you can see is that with the different feature of histology, different genes are expressed. So the lymphoid type are in blue, the myeloid type in red, and the fibroid type in green. And so what it shows is that at the time of presentation, obviously all these patients have active inflammation because they have not had treatment. And yet this inflammation is driven by very different biologic pathways. So this is summarized in this figure we published in 2013, showing that inflammation that we perceive clinically does not necessarily tell us what is the underlying biologic process that produces that inflammation. And in different patients, different cytokines and cell types are in play to produce the clinical feature. So not surprisingly, what we find is that there is no treatment that is effective in every single patient with rheumatoid arthritis. So this principle that the biology that underlies inflammation may well be associated with the response to treatment was tested in the proof of concept personalized medicines trial called the R4RA study that was published in 2021, led by Constantino Pesalas, and I had the privilege of being involved. It tests the principle is that if a patient have a B cell driven disease in the joint, then we will predict that these patients will respond to a B cell directed therapy. But if patients do not have a B cell driving inflammation, then we would not expect them to respond to B cell treatment. And in this study, patients who have failed a TNF inhibitors were randomized based on the histological feature to treat two treatments, either tocilizumab or rituximab. And what this study shows is that in the patient who don't have B cell infiltration or B cell gene signature in the joint, then in fact, they're far less likely to achieve a high response, a CDAI response of 50% or more, and achieve CDAI remission. They are far more likely to benefit from tocilizumab than with rituximab. So it is the first proof of principle study to show that if we know what drives the disease in the individual patient, then we will be in a better place to give the patient the correct treatment or predict response to treatment.
3 minutes
in
left.
summary, what I've suggested to you is that as rheumatologists, we are a bit spoiled for treatment options. And in fact, we have been even more spoiled recently with the approval of several JAK inhibitors for the treatment of RA. We know that JAK inhibitors have demonstrated similar efficacy to biologic agents, but they have a different safety profile, and there's still some unknown safety issue associated with venous thrombosis, also with MACE and malignancy. Nevertheless, we know that JAK is a proven therapeutic target in RA, although we do need to understand better about whether the inhibiting different isoform will have different implications. We also have new mechanism of action being assessed in RA. This includes GM-CSF, the targeting IL-6 cytokine itself, and the Bruton kinase inhibitors. And at the moment, although we have many treatment options, a major unmet need is to